disorders in pregnancy, specifically within the mother, and the physiological aspects that happen when a mother is using these drugs to help with mood stabilizing throughout her pregnancy. So a little bit of background. If mood disorders aren't treated during pregnancy, there is an increased risk for the health of the child or the unborn fetus, as well as the mother. And that's because there's a lot of things going on hormonally, as well as biologically. If these disorders aren't treated, if they need to be, then there could be serious consequences for that as well. So guidelines for managing major depressive disorder and bipolar disorder during pregnancy generally stress the importance of close clinical monitoring and the preconception of treatment planning. So a doctor needs to be fully part of the process when determining what drug to be using and the dosage amount, because a lot of things are changing within the body during pregnancy. Okay, and a little bit more. Changing pharmacological treatment during pregnancy is complicated by pharmacokinetic changes, like I said. So the body is going through all these changes, and hormones and the drug itself is going to be balanced differently throughout time. So the treatment needs to be seriously considered for that. And again, it's very different for every person. So one drug might be specific at a dosage for one person, it might be completely different for another. So dosage levels need to be very much monitored along the way.
Okay, and this paper was pretty technical, so I tried to give a little bit of explanation of certain things that I needed clarification on to understand what the paper is saying. So one thing is the therapeutic index, which the equation for is right there. This is the index of a drug. It's a safety window. So they test the drug on the population, and 50% that experience a toxic dose is the TD50, and that is divided by the effective dose, which is also measured from 50% of the population. So the TCAs is tricyclic antidepressant, and the therapeutic index for these drugs is very low. So that means that you could take, for most TCAs, you can take 5 doses and overdose. For SSRIs, selective serotonin reuptake inhibitors, the toxic dose is, you'd have to take 75, so there's less risk there. So therapeutic drug monitoring can optimize dosing to avoid supratherapeutic dosing, like I said, overdose, underdose, or drug-to-drug adverse effects. Excuse me, I have a little bit of sickness right now. Okay, so here we're summarizing a review that had 166 references, so it's a lot of information. We're looking for evidence of perinatal pharmacokinetics. Perinatal is the period surrounding birth, so usually 5 months prior to giving birth and up to 1 month after. We're looking at potential risks for undertreated mental illness for both the mother and fetus. So this would mean, what is the risk if the mother is not treated with the drug? Stress, depression, manic, those type of things also affect the baby. The risks, and we're looking at the risk and benefit of non-pharmacological treatment, benefits of psychopharmacological treatment. And then we will discuss implications for clinical and therapeutic drug monitoring. and make clinical recommendations. And again, therapeutic drug monitoring is making an actual measurement of the drug concentration in the blood plasma. So the materials used for this review were cross-referencing analysis of all relevant articles found from PubMed or Medline between the years of 1966 and 2013. So that's a lot of years of data that describe therapeutic drug monitoring during pregnancy or the postpartum period, which is after giving birth. These include observational studies, case reports, and case series. So, the pharmacokinetics of during the perinatal period. So, what is pharmacokinetics? It's basically just how your body handles a drug. And physiological changes during pregnancy influence maternal pharmacokinetics without any drug anyway. So the things that are involved are absorption, which is decreased. Distribution is also increased in pregnancy, and then metabolism and elimination is increased. Together, these changes during pregnancy usually result in increased blood plasma volume, which means a decreased concentration of the drug. And so therefore, dosage is, dose increase, especially during the third trimester, the later part of pregnancy, is recommended. And so again, we were just looking at maternal, the mother's benefit in health, right? Especially in this review. So the data on this information is scarce because of the ethical issues surrounding testing on pregnant women.
So next, Maggie's going to go into the distribution of the blood plasma volume and how that changes in pregnancy along the term from start to before delivery.
Yeah, so I like graphs. So this graph is I just found it. It shows the 40 weeks gestation, it will be the giving birth time. So by that time, the plasma volume raises very much. And because distribution is generally decreased during pregnancy, like I said, the blood plasma volume increases and then drug concentration decreases and also drug efficiency decreases. So the metabolism, we are mainly looking at, in metabolism, the phase 1 metabolic cytochrome P450 enzyme family. It is the body's first defense against foreign compounds that enter the body. This enzyme family also detoxifies endogenous molecules produced by the body, like steroids. And also, once the drug goes into the body, these enzymes can break it down and form daughter compounds or metabolites, which are either active or inactive. And some drugs actually depend on the daughter compound activity to work. And there are about 50 different isoforms of this enzyme, so it's a lot. We are looking mainly at 6 of them that metabolize 90% of drugs. And then I gave you examples. The CYP and then number letter thing is going to be the way that we refer to them for the rest of this presentation. The next group of metabolic enzymes that we're looking at are in phase 2 of metabolism, and they include uridine, gluco, UGT, and acetyltransferase. Okay, this is another graph that just shows the general change in hormone level throughout pregnancy. So we see the estrogen and progesterone rises significantly by the end of the pregnancy period. So drug metabolism increases during pregnancy, which decreases drug efficiency. Also, sex steroids like estrogen, progesterone alter enzyme activity. They either induce or inhibit these enzymes. If they're induced, this increases metabolism further and decreases drug duration and intensity. If the sex steroids or hormones decrease metabolism, then there's increased drug duration and intensity. Also, maternal phenotype is an important determinant in drug-to-drug metabolic ratio. And the classifications for these phenotypes are poor, intermediate, extensive, or ultra-rapid. Ultra-rapid being the fastest metabolism of a drug. Sometimes in this case, the drug doesn't even have a chance to elicit its effects. In elimination, altered hepatic clearance. Basically, the liver, when the drug goes into the body, it's absorbed through the intestines, and then it goes into the blood, which it has to pass through the liver then. The liver is the most important organ for elimination and metabolism. Elimination can also occur by the kidneys. If you guys have any questions, feel free to interject.
I have questions. Are they able to tell in an infant's first month after birth if the mother was depressed, if it was not properly treated for, let's say, mental problems during pregnancy? You said it affects both the mother and can affect the child. Can they tell during the first month of the child's birth, existence?
Yeah, I mean, from this review, it didn't go into that, but we were interested in that, so we did some other research. And mainly what I found is that the main changes that occur based on the drug or the mood disorder is gene inhibition or activation. Usually changes the length, like the normal time for which the gene should be activated. And so these can be determined to some extent in the first month, but I mean, it's not really evident. I read some case studies about they followed children throughout their life whose mothers were on antidepressants, and they didn't find substantial results. There are really no substantial results yet on the area of the fetus.
Right, and a lot of the longitudinal studies look at physical being malformed, so having maybe a cleft palate or any of those kind of issues that can arise, but with those drug interactions. But all these longitudinal studies are looking at children up to age 6, so we don't really know past that age. There's cognitive impairments through different tasks that they can do and play with the child to see if there's anything that's going on.
The slide says there was an effect on the children.
Yeah. We kind of thought, we were just discussing it because that's how they introduced the paper, that there are effects on the mother and the fetus, but they really don't even go into it, so they were very generalized when talking about that, so.
Thanks.
Mm-hmm. We're going to talk a little bit more about it later on in here. So the 4 of the cytochrome P450 isoforms that were mainly discussed are here. And the first 3 are inhibited by sex steroids, and the last one is induced. You don't really have to pay too much attention to this unless you really care about studying enzyme isoforms. The important things to point out here are that for the first one, inhibition reduces the activity of the enzyme by 65 to 70% by the end of pregnancy. So that's a lot. And then in the third one, pregnancy is shown to reduce enzyme activity by about 50%. Okay. So evidence for changes in the perinatal phase 1 metabolism for antidepressants. First, we're going to cover SSRIs. So here we have listed, the first 5 are probably some of the most common SSRIs, the ones that we see on the commercials, and the metabolic isoenzymes that are involved in drug metabolism. Trying to think of what's the most important things to just explain. I'm going to go to this graph and then go back. So these are 2 examples from the previous table. The first one is for Celexa, and basically what I just want you guys to see is that from 20 weeks, which is like the middle of the second trimester, to delivery, we see like a steady decrease in the drug concentration levels in the blood. And then after the delivery, there's a spike. So during this time, like if the mother has to increase her dose for the antidepressant in order to maintain euthymia, which is a non-depressed state, then they have to decrease the dose after the baby is born. The problem is that everybody is different, so you can't predict whenever the person's peak concentration level will be. It can be anywhere from 2 to 6 weeks after the baby is born. And then another thing I just thought was kind of interesting is that the US, the FDA, categorizes these drugs in pregnancy based on risk. So all of the SSRIs and SNRIs and TCAs, which is tricyclics, are categorized as C, which is insufficient evidence to indicate any risk. The only one that is not identified as C is Paxil, which is D, which means that there is evidence for risk. And this is because depending on the metabolizer type, if you're ultra rapid or extensive metabolizer type, which is just fast metabolism, then there's an opposite effect of the isoforms to decrease or increase metabolism. But then if you have a slow metabolism, it's the other way. So nobody knows. So you can you can need an increase or a decrease in the dose, but they won't know unless they test your enzymes for metabolic phenotype. Okay, and I literally just made this slide because I decided that I wanted to include what happens to the baby. So they don't talk about this for SSRIs at all. So there's a lot of information because I didn't have time trying to simplify it, but basically the important things are the Ssri exposure alters vascular parameters in the fetal placental compartments. And then for Celexa, there were, this was the study that I was talking about where they followed the children. They followed like 11 children whose mothers took Celexa, and they didn't find any neurological developmental issues, but that was all they were testing, and they were only testing or only observing 11 people, so the sample size is not like sufficient. Okay, then for fluoxetine or Prozac, this is like the most common antidepressant. Exposure before birth did not statistically alter gestational length. So that's how long the baby is stuck inside of the body. But it did affect litter size and spontaneous loss, but this was found in mice. And the author of this statement said that this definitely warrants further investigation. And then also serotonin is involved in embryogenesis, and also the serotonin transporter is expressed in early embryos. Exposure to Prozac may alter time between embryonic gene activation and morula formation. This is morula after fertilization. So the gene's activated like very short time from when it's one cell to this many cells. Okay, and then SNRIs are selective norepinephrine reuptake inhibitors. There's only studies found in all of those years that these studies were taken from for two, Effexor and Cymbalta. And for Cymbalta, there's even insufficient data to recommend any dose increases during pregnancy. And then for Effexor, metabolism is consistent across pregnancy and postpartum period. There's, I think, only one report that they said calls for a twofold increase plasma level in postpartum. But basically, like, there's just insufficient evidence for a lot of these things. Other antidepressants that are popular, Wellbutrin, Remeron, and then Trazodone. And there's insufficient data for all of them. And then tricyclic antidepressants, last group for mine. They all decrease plasma levels. So that means, again, the drug concentration in the plasma level is decreased in lower drug efficiency for all of these. So there's a dose increase suggested after 20 weeks of pregnancy. The final dose required during pregnancy to maintain the therapeutic drug level is 1 to 3 times the preconception dose. So that means when the blood plasma level concentration decreases, there is suggested to increase the dose by 1.3 to 2 times the amount. However, no pharmacokinetic studies in pregnancy for TCAs despite low therapeutic index. So the therapeutic index is only 4 to 5, but the suggested dose increase is 1.3 to 2. So it's like way too close to be like increasing someone's dose during pregnancy if you don't understand how their genes and their pharmacodynamics and kinetics is working. So the prevalence of women suffering from depression in this country is estimated at 5 to 15%. It's a lot. there might be a relationship between maternal SSRI use and infantile hypertrophic pyloric stenosis, which is projectile vomiting during the first month of life. Furthermore, findings suggest the possibility of an association between the use of SSRIs during pregnancy and abnormal function of the GI tract. No fetal studies found on TCAs, despite the low therapeutic index. High risk for toxicity.
Okay, so now we're going to go ahead and turn over to evidence for change in perinatal metabolism of mood stabilizers. And I'm going to go into specifically 4. Okay. So during pregnancy, the clearance rate for these drugs increases substantially, like Maggie was saying. You need a lot more of a dosage to have the same effect, to not go back into a potential relapse. So the high dosages are needed in order to have those same safe levels of normal mood. And this is seen specifically in the 3rd trimester. So like we saw in one of those graphs, there was a peak. So, and that was after birth, because you're getting a high dosage at the 3rd trimester, and then after delivery, you're having higher dosage in your system, and then that could lead to possible toxic effects, which is not what we would want. So the dose should be very carefully monitored through your doctor and moving forward after pregnancy. So I went through that. So the first mood stabilizer that I'll be going through is lithium. Lithium is used to treat bipolar disorder, and it is the first choice agent in treating bipolar disorder in pregnancy. It has one that we found potential birth effect, and that's in roughly 1 to 5%, and that is a heart defect where the valves aren't forming correctly during pregnancy. And that's when they are exposed to lithium in the 1st trimester, so right in the beginning. So doctors need to make sure that their dosage is the lowest that it can be to have that effective amount of not going through relapse. Again, these studies through this review did not see any other physical or behavioral or even mental deficits in these longitudinal studies moving forward. And then again, reiterating this fact is delivery should be carefully monitored, because these levels are going to change drastically in the next couple days, in the next couple weeks after delivery. Okay, and then the next mood stabilizer is lamotrigine. It is, again, one of the most widely used drugs for treatment of bipolar disorder and epilepsy. Clearance of this drug increases substantially at the onset of pregnancy, just like what we saw in lithium. And the clearance potential is 300% of what it was before pregnancy. So you need a much higher dosage to have some of those same effects, which can lead to, again, very high toxic levels after birth, because you have a lot of this dose in your system already. And it's very important to get this drug to get back to normal dosage levels right after delivery. And this is seen in 25% of women that are taking this drug. So that's a high number. We don't want to have these toxic effects, but this happens a lot more than probably we would like. So women that have epilepsy need to have higher amounts in their system so that they, again, don't fall under that relapse category. It is one of the safest for women in pregnancy because it's been researched a lot, but again, not substantially enough that we can make full claims with this. And one more thing on this drug, there has seen less malformations of that fetal development, so less physical damage or cognitive impairments than other epileptic drugs. Okay, then we have carbamazepine. It is metabolized hepatically, so through the liver, and it's converted to an active metabolite. And it induces that P4 50 system, which increases the metabolism of drugs taken concurrently. So if you're taking other drugs, that could increase the metabolism of others and kind of work away from that dosage level. So they're kind of interacting in a way that they wouldn't if you were not pregnant. And again, more work needs to be done. There's a 1% chance of neural tube deficits, which happens very early when in pregnancy. And no other deficits have been seen other than this neural tube deficit so far in the research. Okay, the next is VA. It can be used to treat bipolar disorder again, epilepsy, and also migraines. It should not be used as the first line of as a first line stabilizer in women that are at reproductive age, because once you start a drug, it's hard to get yourself off of it and then maybe start another. So it's good to start off with another kind of drug. But this is not seen. So doctors are still prescribing this at age where women can or want to start a family, and that can be seen as having a lot of deficits in the fetus with that neural tube and also cognitive impairment. So research has been done that women should not be taking this at their certain ages, but it's still sometimes being prescribed. There are higher rates of birth defects, like I said, and that's during the first trimester, so being exposed to this drug earlier on in the pregnancy. And it crosses the placenta very early, so this baby's getting exposed to this drug early on in that first trimester. Okay, so these mood stabilizers. How informed, these are just a couple of questions that I was thinking about while reading the passage, and that is, how informed should patients be about the drug that they're using? So does a patient need to know coming in, okay, I have bipolar disorder and I'm treating it with VA, but I want to maybe start a family? Should they know from the beginning, oh, I need to do some legwork behind my doctor, because what if my doctor prescribes it and then there is more potential for deficits where I could be taking another drug and I wouldn't see these kind of effects possibly as much as this other drug has seen. And if these doctors have the authority in the scenario, so they kind of know more than these patients that are going in, should we be trusting the amount that they're prescribing us? What do you guys think about this? Should we trust our doctors fully? I know we would like to, and we want to, but do we feel like we need to have this kind of legwork going on behind the scenes to see what kind of deficits should be happening? Obviously, yes, right? But in a perfect world, they would know, they'd be all-knowing, and there's still work that needs to be done. And how much trust, like I said, should be in these? Okay. Then we're going to go into discussion and clinical recommendations that the review went through.
Okay, so this drug dose effect and the therapeutic drug monitoring relationship is very complex, as we have seen. It includes individual differences in pharmacokinetics, pharmacodynamics, and genetics. Individual changes during pregnancy may or may not lead to changes in drug metabolism depending on the person. Changes do not necessarily lead to an altered clinical status either, so even if drug concentrations change, doesn't necessarily mean that there will be a reoccurrence of symptoms. And if there is, you cannot tell to what degree. Evidence from this review shows that SSRI levels fluctuate during pregnancy, but these results are not yet clinically established because there's not enough studies done and there's not enough evidence. Data suggests that pregnant women may require dose increase to maintain drug effect. Some, not all women, have faster SSRI metabolism during pregnancy. Most SSRIs require like around a 2-fold dose increase during the 3rd trimester. So the first clinical recommendation is that evidence supporting routine therapeutic blood level monitoring for antidepressants other than TCAs is insufficient. So this means if you're prescribed a tricyclic antidepressant, you are required to get your drug levels monitored because it has such a low therapeutic index. However, there's no information, even when I tried to find information outside of this review on TCAs in pregnancy and the changes that occur. So this therapeutic drug monitoring needs to be measurement-based. And so as research increases and there are more studies done in pregnancy on these drugs, we need to develop a standardized assessment to use for clinicians to use in therapeutic drug monitoring. Also, SSRIs do not have any established therapeutic range at all. This review suggests a target serum, so basically, like, if you're gonna get prescribed an antidepressant, then or even a mood stabilizer, then whenever you're asymptomatic, like the drug is helping to mitigate your problems, they will take your drug level concentrations, and so in the case that you get pregnant, they can use that as a guide for adjusting dose. And then studies need to be done to determine if the strategy would improve clinical care and also cost effectiveness. Can't forget that. The second clinical recommendation is due to the fact that in 2004 the FDA recommended tapering patients off antidepressant medications by the third trimester, which is directly contrasting the evidence that we've shown you. And they said that this would reduce risk of complications resulting from fetal exposure to the drug. However, yeah. So the clinical recommendation is close clinical monitoring to address adverse effects if they occur, especially during the postpartum period when the drug concentration levels spike. Also, they mentioned to make sure that if adverse effects disappear, don't immediately increase the dose, which seems kind of logical. Clinical recommendation number 3. In pregnancy, they recommend monthly monitoring for drug level concentrations, especially during the third trimester. And then in the postpartum period, monitor patients for adverse effects and taper drug to preconception dose to mitigate adverse effects. Got it.
Okay, then again for mood stabilizers, like the ones I went through, women that are taking these drugs while pregnant have a much higher risk of relapse after they give birth. And that's, again, because of the dosage level changing and the body interacting with this drug and metabolizing it different during pregnancy, and then your body kind of being in shock of this change that's happening drastically after delivery. So like Maggie was going into, the therapeutic drug monitoring is essential for these drugs and using them during pregnancy. And that's so we don't have these toxic effects happening after birth, and we don't have possible deficits in the child. And this is well established, the review said, for lithium. Maybe not enough, but that's what is brought on so far versus other mood stabilizing drugs. And it's important to check those levels every trimester, and even, I would think, even more, so more than just a couple of visits, because that dose is going to be needed to be upped and then decreased again. Should be staying on the lowest effective level, sustained release before pregnancy for more stable levels. So getting that reading of how much is needed before pregnancy, and then how much the dose should be increased as they go on, and then after delivery, having that standard matched from the beginning. Okay. And then further recommendations, deciding to use mood stabilizers is a very complex decision. Some people might decide not to take them altogether, and again, that could see even more adverse effects, more than what this review covered, but like we said, there's biological effects, physiological, psychological that can happen from both the mother and the fetus if it is not taken care of. And clinical monitoring is key. That's a big point in this. We need to make sure that the patient is going to doctor visits and making sure their dosage levels are where they need to be. Okay, so let's talk a little bit about the ethics. After all this information, we need to just kind of break it down to a smaller level. Is it okay for women to take mood-altering drugs while pregnant? What do you guys think? Yes? No? After the information we gave to you? Yes? No? I see some nods. Some nods. Yeah. Because it's going to, in the long run, help with this mood stabilizer, but there's still not enough research out there. So it's kind of like a yes, no, maybe, because there needs to be a lot more work done, right? I think we all have that consensus.
I have a question.
Yeah.
Did you run across any evidence that kind of linked maybe a higher probability of postpartum depression with people that are already taking antidepressants? And if there is, which I could see how that could be so with all the different changes and that are going on after delivery. So what would one do then, if on top of everything they showed signs of postpartum? Or would you even be able to tell the difference?
Well, I think that you would be able to tell the difference based off of their mood and reacting to their newborn child, and how they're reacting with each other, and that relationship, that bond. But those dose levels, like you said, are going up and down, and we don't see. Maybe we won't be able to see a change. What are your?
Yeah, I mean, from all the things that I read, basically, I think that increased postpartum depression of women who are taking the medications, the antidepressants, is actually less likely, but the more likely thing to happen is the adverse side effects of the drug, because the concentration spikes in postpartum. Of course, there's like a lot of variability, like I said, and each person is different, so metabolizer rate contributes, but I did not read anything on increased postpartum depression, only increased adverse side effects. That's possible.
Okay, so one more. Do the benefits of taking them outweigh the potential risk of the child going through, say, a withdrawal because of the different dosage or having different side effects? So should the child be exposed to maybe having deficits after they're born? Or do taking these drugs help with the overall composition of chemicals and metabolism and all of the associations of, this drug happening in their body, and then being able to keep a normal level of mood or stabilization?
Sorry, the question.
Yeah.
That doesn't answer your question.
It's fine.
But, so when you're talking about mood-altering drugs while pregnant, it seems to me there are at least two categories. Those people who were on something beforehand, and now you're trying to maintain a level where things don't get worse, where they stay stable. And those people who maybe during pregnancy experience changes in mood, and are they to be treated differently? And how do you address that? Or maybe it wasn't addressed.
Yeah, I mean, it's not considering people who, like, I think you're saying basically, like, the person is kind of normal, and then they get pregnant, and then they get depressed.
Yeah.
Right, so the reason that the drug effect decreases during pregnancy is actually not related to getting pregnant during, to getting depressed during pregnancy,
Yeah, I
because
know that.
the drug effect, it goes into the body and it binds to things in the brain that cause less depression, but those things are unnatural, synthetic, and the actual changes that are occurring are in the liver. So if your body is like producing serotonin, for example, it just does that. The brain does that, not the liver. But for the drug to get through the body and work in the brain, it has to go through the liver, where the enzymes are altered. Does that make sense? Yeah. So it's not even related. Like,
So you're not talking about that category
Yeah.
of people. That's what I'm saying.
right.
Okay.
Would a doctor prescribe something though? Like if you ended up being pregnant, had no history of depression, but you ended up depressed like second trimester, would they prescribe?
Yeah, I don't know,
I don't know.
but I doubt it.
Yeah.
Because the
There's
side
not a
effects
baseline.
are
Right.
worse to like start a drug.
So they would probably attribute the depression to the change in hormone level.
Yeah. I mean, they might, but then like you have to also consider the fact that when you start trying to take the antidepressant, they have to keep like changing the dose in order to figure out what dose works for you.
Would they be doing that if you were already taking it before and you were pregnant anyways, wouldn't you?
Right, but usually before you get pregnant, you're already at the dose that's working.
Yeah,
for you.
I'm saying like when
what
you
it's
become
assuming.
pregnant, they have to constantly keep changing the dose to keep up with how you're metabolizing it.
Yeah,
So
I mean,
it'd be
you're
the
right.
same- It would be the same situation if you were to start prescribing it and having to figure out what dose works as
So you didn't
well.
have a baseline, you had before baseline.
Does that matter?
I mean, in my mind, not based on what I read, it just seems that, like a person may try one antidepressant and it doesn't even work for them because they don't have the genes that encode for proteins that bind the synthetic neurotransmitter that the drug produces, or for example. So you have to try different ones because each one has a different mechanism.
Okay.
So I think like that is high risk, but they might do that. I mean, who knows?
So then, the other debate is what's the autonomy of the unborn fetus? This is an ethics course. We have to address that. The fetus doesn't have a decision in the matter. So, is the mother do we trust the mother to do what's best? Or the doctor? Well, thank you. This is the end of our presentation. If there's any other questions, we can address them. No?
Dr. Kabani is going to be back with her emergency. Some